As the number of immunocompromised patients rise in our hospitals, the presentation of severe infections caused by herpes viruses, particularly herpes simplex viruses and cytomegalovirus, are definitely rising, and we are seeing more and more. Most importantly, the lack of response and the documentation now of resistant strains are becoming more frequently observed and threatening the success of our antiviral agents against these organisms. So today, in a very, very topical field, we will discuss these issues of antiviral resistance in herpes viruses with experts in the field. So welcome to Editors in Conversations. The objectives of this podcast is to understand the clinical problems caused by resistant HSV and CMV infections, discuss a little bit about the mechanisms of resistance in these organisms, and provide some insight into novel therapeutic approaches to treat resistant herpes virus and CMV infections. So this episode is brought to you by antimicrobial agents and chemotherapy, available at asm.org /journal/AAC. I am your host, Cesar Arias, Editor-in-Chief of Antimicrobial Agents and Chemotherapy. This podcast is supported by the American Society for Microbiology, which publishes AAC. This is part of our Editors in Conversation series, which we do in conjunction and in partnership with the Journal of Clinical Microbiology. If you plan to publish in AAC, ASN members get up to 50% off publishing fees. So it's very good to become a member of the American Society of Microbiology. Visit asm.org/membership to sign up. And don't forget to check our latest issue of AAC, available at asm.org/journal/AAC, with outstanding papers on mechanisms of resistance, pharmacology of antimicrobial agents, epidemiology, and clinical therapeutics, among others. We also have a new collection in our website with all papers published in the section New Perspective on Antimicrobial Agents. And we're about to launch a new section on antimicrobial stewardship led by two of our editors, Drs. Pranita Tama and Ryan Shields. So stay tuned to this announcement. Joining us to discuss this important topic today are two real experts in this herpes and viral infection. Dr. Christine Johnston, who is Associate Professor of the Department of Medicine, Division of Allergy and Infectious Diseases, and Adjunct Associate Professor of the Virology Division at the Department of Laboratory Medicine and Pathology at the University of Washington, Seattle, Washington. And a good friend of mine, Dr. Roy Chemali, who is Professor of Medicine and Chief of Infection Control Officer, Director of Clinical Virology Research at the University of Texas and the Anderson Cancer Center in Houston. Welcome to the program. So this is a very, very interesting topic. We've been talking about antivirals for a long time, but only to one disease. And I want to go back to the day-to-day what we are seeing, particularly in our immunocompromised patients. So the interesting part of this is that we are seeing this more and more as we see our immunocompromised patients and in some immunocompetent patients too. So let's start with Christine. So let's talk about HSV viruses. Where do we see this difficult to treat HSV infection cases?
Well, thanks for having me, and I'm really excited to talk about HSV-resistant infections today. We do see increasing numbers of acyclovir-resistant infections, and mainly in immunocompromised hosts. As you mentioned, patients who are getting stem cell transplants, as well as people who have advanced HIV infection with low CD4 counts. We are usually now using acyclovir prophylaxis for patients who are undergoing transplant, but even despite this, we are seeing some patients with acyclovir-resistant herpes, particularly in those who have complications such as GVHD.
And I imagine we are now making that diagnosis more readily available thanks to sequencing, or is that part of the topic that we are better at diagnosing these resistant infections?
That's a great question. And really, the gold standard diagnosis is still phenotypic resistance testing. So that is mostly how the diagnoses are being made. There is actually at University of Washington, there is an available sequencing option for making the diagnosis.
Okay. Yeah, if I may add also, Caesar, that for this herpes simplex virus resistance or refractory, it may become more and more common in the future when we have now other modality to treat at least underlying malignancies with targeted therapy, especially with CAR-T, although we do a good job in preventing it with acyclovir, as Christina mentioned earlier, but we may see some breakthrough infection, and that's why there is some unmet need to treat these difficult cases.
So yeah, that's fantastic. So Roy, now that you gave the lead on this, how about CMV? We see a lot of this, and more we see these difficult cases to treat. So in what setting? And I know you work in a cancer center. What settings are you seeing these infections that are difficult to treat?
Yeah, so CMV is probably one of the most common infections that occur after allogenic stem cell transplant in recipient positive or CMV seropositive recipient, but also in the solid organ transplant. I think over the past few years, we did some headways in preventing CMV reactivation after allo transplant by using an antiviral agent, which is letermovir. But before the era of letermovir, these difficult cases were much more common in the setting of allo transplant. Now we're still seeing some infection, especially breakthrough infection, later on resistant infection or refractory in the allo transplant setting. But in solid organ, I still think it's still the case where this kind of cases could be, our transplanter could be faced with on a daily basis.
So, let's talk about drugs that we normally use. So let's talk about the prophylactic approach. You see, so all these patients that we think are at risk of this reactivation, because these are viruses that basically live with us, and most people get infected very early in life. So, Christine, let's talk about prophylaxis with for HSV infections. What kind of drugs we have? Maybe talk about a little bit about mechanisms of actions and all that.
Sure. Well, we've already mentioned acyclovir, and we also have valacyclovir and famciclovir. These are 3 oral medications that are used to treat HSV infection. And the strategy, particularly in people with advanced immunocompromise who are known to be at increased risk to reactivate HSV, is to use suppressive therapy. So this would be a daily therapy taken to prevent reactivation of the virus. Now, in terms of how these drugs work, all of the available oral antivirals are nucleoside analogs, and they're really interesting drugs. They are they're activated, and the first phosphorylation is by a viral thymidine kinase. So they really aren't active in cells that don't have that aren't infected. The subsequent phosphorylation occurs by cellular enzymes, and then these are incorporated into the growing DNA chain and cause a chain termination. There are also other medications. Foscarnet is the main one, which is only available IV and has a lot of toxicities that can also be used to treat resistant HSV infections.
Okay, so but usually not for prophylaxis, right? So you get to the nucleoside analogs. So,
yes.
So Roy, let's talk about prophylaxis in CMV infection. And I know there are several approaches. It's a big topic, but let's see what your expertise can tell us.
Yeah, so for many years, actually, we had ganciclovir available, or valganciclovir, as well as foscarnet that Christina mentioned. Unfortunately, this drug, we know they are effective drug, but they can cause serious toxicities. That's why in the allogenic stem cell transplant setting, we don't use them for prophylaxis, or rarely use for prophylaxis. We use them for preemptive therapy, meaning you allow the viral load to reactivate or to be positive a little bit, then you treat for a short period of time. And the reason is because myelosuppression from ganciclovir and valganciclovir, and nephrotoxicity from foscarnet, or even cidovovir that has some anti-CMV activities. Now, over the past 5 years, things change. I would say there's some paradigm shift in approaching CMV after allotransplant by using prophylaxis with a safe and effective drug. It's oral and it is available in IV format, which is letermovir, which was approved in end of 2017 to prevent CMV reactivation after allotransplant in seropositive recipient. So now, over the past few years, we've been using it for prophylaxis, and it's working very nicely. We are reducing the incidence of CMV reactivation after allotransplant.
Yeah. So what's the difference of letermovir with the other drugs in terms of mechanism, maybe, or resistance?
Yeah. So the previous drugs, ganciclovir or Valgan and foscarnet, the end product is inhibiting DNA polymerase. Foscarnet works directly on the DNA polymerase of CMV, and ganciclovir needs phosphorylation with the kinase, which is the UL97, and then it will act on the DNA polymerase as well as cidovovir directly on the DNA polymerase. Now, letermovir, the new drug for prevention of CMV, has totally different mechanism of action. It works on the CMV terminus complex, which is the UL51, 56, and 89, which is needed in order to cleave the DNA elongation and then packaging later on and forming of the virus. So different mechanism of action. There's no cross-resistance between letermovir versus ganciclovir or foscarnet and cidovovir.
So, Dr. Johnston, we introduced this term preemptive therapy when CMV became sort of part of the jargon. Has this approach ever been attempted for HSV infections, in particularly immunocompromised patients?
It really hasn't been used for HSV infections. And I think the reason why is we're fortunate with acyclovir and valacyclovir. These drugs do not have the toxicities that are seen with Valgan and ganciclovir. And so we are able to use them as suppressive therapy. They are used for different periods. So I think sometimes what we're seeing is late reactivation and resistance of the virus of HSV. As well. So one other thing I just wanted to comment on is that for HSV, these drugs that we have were approved about 30 years ago. So I'm really very jealous of Roy and the CMV world that you have some new drugs with new mechanisms of action to change the approach to treating CMV at least.
What do you think that is? Is because people don't think we need more drugs against HSV because it's probably not as maybe difficult, or we don't see it. What do you think that is?
I think it's good and bad. I think acyclovir and the other nucleoside analogs work pretty well for HSV. They do a good job in suppressing the virus in most patients. They can, treat the infection in most patients, but there definitely are limitations of them. And so I think, and we know that particularly in very immunocompromised patients, there's breakthrough even with suppression, obviously breakthrough shedding and then breakthrough resistant infection. So, but I think that's why we haven't seen more interest in this space.
Okay. Yeah, I agree with that. If I may comment, Cesar,
Sure.
I totally agree because it is kind of pretty effective prophylactic strategy, right? With acyclovir or valacyclovir or other pro-drug as well. That's why we didn't feel the. And also, when we are faced with some difficult to treat cases, then we go to foscarnet, like Christina mentioned earlier. Although it's pretty toxic, but we have to use it sometime, not all the time. So that's why probably people didn't feel that there is unmet need. Although us working in this field, in this world, we think absolutely. We are seeing more compromised patients and we're seeing more kind of a little bit more breakthrough infection that we need other drug with other mechanisms of action different than acyclovir in order to address this kind of unmet need.
Yeah. One of the main impetus for this podcast, we just published a case with a new drug So we'll talk about that in a minute for HSV. So I'm very excited to get to that point. But before that, Christine, why when don't we talk about resistance? So the resistance to those nucleoside analogs and possibly post-carnet. So what are the common mechanisms of resistance and how that those manifest clinically?
Yeah, so I mentioned that the mechanism of action for acyclovir is that it is a nucleoside analog that needs to be phosphorylated by a viral thymidine kinase. And that viral thymidine kinase obviously is only going to be in cells with the virus present. But that viral thymidine kinase is encoded by the UL23 gene, and that is where 90 to 95% of our resistance mutations are occurring. The remainder of resistance mutations do occur in DNA polymerase. And I should mention that for all of the oral nucleoside analogs, valacyclovir, acyclovir, and famciclovir, there's kind of cross resistance with, if there's UL23 resistance, it will affect all of the drugs. For foscarnet, if it's a UL23 mutation, foscarnet may still be effective because that is targeted by the DNA polymerase. It's targeting the DNA polymerase. However, there are, again, DNA polymerase mutations which could also cause resistance to foscarnet.
Okay, and that's a great explanation, Roy. How about in CMV? We have these drugs also. Valganciclovir, ganciclovir, foscarnet, and cidofovir, and maybe letermovir. Can you just walk us through a little bit into the mechanism of resistance that we commonly see in those against those drugs?
Yes, absolutely. As I mentioned earlier, ganciclovir and valganciclovir need the kinase to be phosphorylated before they act on multiple phosphorylation before they go and act on the DNA polymerase to inhibit DNA polymerase. So if you see specific mutation, specific codons on UL97, which is the kinase, then ganciclovir will become resistant, or CMV become resistant to ganciclovir and valganciclovir. So this is one part, which is the L97. So many mutation can confer resistance to these two drugs. Now, for foscarnet and cidofovir, as well as ganciclovir, DNA polymerase, which is the UL54 encoding for DNA polymerase, when you see mutations, specific mutation, you may get resistant to either foscarnet alone, ganciclovir alone, cidofovir alone, or some mutation can confer resistance to the three drugs at the same time. Also, it's not that common. Now, for letermovir, because different mechanisms of action, the termin is complex, what most of the mutations that we may see from letermovir, it's going to be on UL56, usually the specific mutation conferring resistance to letermovir if you are using letermovir as well. So there's no cross-resistance between letermovir and the other drug, but they may be cross-resistant between ganciclovir and, of course, valgan with cidofovir and foscarnet.
Okay, that's fantastic. Okay, so let's now go back and let's say we are treating usually immunocompromised patients, as we happens every day. And let's start with Christine on this. And we recently published a challenging clinical case of a patient in which acyclovir was used for a long time, and there was a lack of response on this. So, what are the current strategies that we have available when we face this situation with HSV? What do you normally do?
So the treatment of choice for treating suspected or confirmed refractory or resistant HSV is foscarnet. And I would say that that is the go-to medication that we try for everyone. The problem is that we often run into the toxicities associated with foscarnet, the nephrotoxicity that Roy already mentioned. You can also get really severe genital lesions actually with foscarnet as a side effect, just from the toxicity of the drug on the mucosa from urine, actually, when it's excreted in urine. As well, foscarnet is intravenous only, and so people have to be admitted to the hospital. It requires a lot of electrolyte monitoring. And so it's really not an easy medication. And I think many the immunocompromised patients who may need foscarnet, they've been in the hospital a lot, and it's a priority for them to stay out of the hospital. So it's really inconvenient as well. Outside of that, the options are cidofovir, also really toxic medication. And then there are some topical medications. You can actually formulate cidofovir to be a topical agent. Imiquimod is another topical agent that's a TLR7 agonist that's been used. But these are really on the level of case reports that they've been successfully used. And so, there's not really a lot out there, and nothing is FDA approved except for foscarnet.
Okay. Yeah. So let's do the same with CMV, Roy. What do you do?
Yeah. So for CMV also, and I want to add in specific, and also as well for herpes simplex, these patients, when they get to a stage when you have resistant infection or refractory infection, they have many other complications. They are heavily immunosuppressed patients. They may have relapse of their malignancies or many other complications related to other type of infections. So that's why when using a toxic drug like foscarnet, you're gonna encounter some kidney dysfunction because you're not using only one drug alone. You may use other nephrotoxic drug on top of it because to treat other complication. Unfortunately, that's what make it harder to treat and very complicated patient population when they get to the stage of resistant or refractory. For CMV, it's kind of the same kind of pathway. We start usually first line is ganciclovir or valganciclovir. If it doesn't work, or we start seeing rising viral load or progressing CMV and organ disease, we may switch to foscarnet. Well, that's what we go for. And keeping in mind, toxicity may occur, nephrotoxicity may occur, and we have to really have close follow-up on this patient, monitoring their electrolyte, fluid intake, and many other. And Christina mentioned the ulceration. It's not as uncommon as people think when you look for it. So we go with foscarnet. If foscarnet doesn't work, cidofovir is rarely used. I don't believe it's a good drug for CMV, except maybe for retinitis when it was developed for HIV. But for CMV per se, after allotransplant, good, and has lots of side effects. In addition to nephrotoxicity, it may cause also myelosuppression as well.
Okay, so I'm gonna throw an oddball here. And I come from the bacterial world. I'm a bacteriologist mostly, about combination therapy. So people think that using two drugs is better than one, even when they develop resistance. There is other strategies to use higher doses than normal. So Dr. Johnston, let's talk about combination therapy for HSV. Any data to support that approach? Is there anything that we can learn?
So I would say there's not really good data for combination therapy to treat HSV, but you do bring up some interesting points that I want to raise. For HSV, the thymidine kinase mutations and the resistance virus, they actually come at a fitness cost. So one of the other possible ways to treat the infection is a continuous acyclovir, and that's sometimes a little counterintuitive for people, but it's really making sure you have high enough dose drug with IV acyclovir to overcome the resistance, and because of that fitness hit. Another thing that's a little bit counterintuitive is that when someone recovers from an acyclovir resistant herpes virus infection, we actually do recommend suppression with valacyclovir or acyclovir again. And that's just to try to prevent that reactivation of the virus and further selection of resistant viral strains. So it is very different than how we approach the bacterial world.
This is interesting because in HIV, we use that approach of the fitness that you mentioned. That's very interesting, to try to select for certain mutations that cause fitness, causing the viruses. But I always think, a virus should be treated with more one drug because they're so much easier to develop resistance. What do you think about that in CMV, Roy?
Yeah, so the issue with CMV is that because the drug available for us to treat this kind of difficult, the cases or infection are pretty toxic drug. So having combination of very toxic drug like ganciclovir with foscarnet or even cidovovir with ganciclovir, it's gonna increase toxicities and it's serious toxicities, right? But we did it few times. What we did in the past before the era of maribavir, we're going to talk about it later on to treat resistant or refractory infection. What we did is we combined ganciclovir with foscarnet. But what we did, half dose of ganciclovir, full dose of foscarnet, because we want to try to mitigate the risk of myelosuppression versus nephrotoxicity. And based on case reports, no clear data if it works or not, but we were hopeless at one point, or we didn't know what else can we do and offer our patient, So we did some combination. But yes, the concept of combination of antiviral is start to emerge. I will tell you, we have a trial at our place at MD Anderson where we're using combination antiviral to treat severe influenza infection. So you're gonna see more and more kind of trial, but you have to have kind of safe drug or not that toxic drug in order to combine it together to see if you impact or you have better outcome in this kind of severe infections.
Yeah, so and I would just to add, I would say you also need the drugs with different mechanisms of action. That's a key piece as well.
So I assume that all those pharmacokinetic modification of higher doses and all that are probably not going to be the best because of increased toxicity. And I guess this data supporting those approaches are also scant. Any opinions on that?
If I may start, I would say for CMV, what we do when we look at the mutation, at least for ganciclovir on UL97, there's some mutations that can confer low level of resistance. So what we did in the past, and this is part of the recommendation or guidelines, increasing the dose of ganciclovir intravenously or valganciclovir, but usually intravenous ganciclovir. We did it on few occasions before the era of the new drug that got approved recently. We increase it, we double the dose or a little bit less than double, but you're going to end up with myelosuppression for sure. But it could be effective in some ways. There's some published cases, as you mentioned, there's no clinical trial for that, but it happened in the past.
Christine, any opinion on that?
I would say we don't really do that for HSV because of the toxicity issues that were already discussed. When we are using combination therapy, I would say we're in a desperate situation, and we may grab for a topical therapy plus topical cidofovir or imiquimod with an IV or oral antiviral. So it's always a desperate situation.
Okay, great. So let's now talk about new drugs. Okay, and I want to ask first Dr. Johnston about this drug that is called pritelivir, which we have a challenging clinical case already published with commentary, also published. Tell us about this drug. It's one of the first drug I've seen new specifically directed to HSV. So tell us about this drug, mechanism of action, and if there are any advantages to use this drug now.
Yeah, so pritelivir, it is a really exciting agent. It's a novel mechanism of action. It's a helicase primase inhibitor. So it actually, where it's working is where the DNA is starting to unwind, and by inhibiting that, you inhibit the replication of the virus. And it's exciting for a couple reasons. One, there's no real human analog to this medication or to this drug. So theoretically, it should be very safe. It's also available as an oral formulation. And it is being studied in a phase 3 trial right now for acyclovir-resistant herpes, and it also has been available under an expanded access program.
And that's how we published that. And I want to clarify, this drug is not yet approved for herpes infection. We published that case that was used as compassionate use. So, and where would you, Christine, where would you use this drug? I mean, you can, argue that once you wait for desperate cases, maybe it's too late. would be any reason to use this drug earlier in the course of disease in particular hosts? Or I guess we're going to learn a little bit more when the clinical data are available.
Yes, I think at this point I would really reserve it for demonstrated cases of acyclovir resistance or refractory disease. It's just we don't have the data yet about the safety, and it actually is difficult to get. I think it's probably not available unless you demonstrate that, because that's what they're really studying to try to get approval for this drug. I will say that many years ago, it was studied for genital herpes as well in clinical trials, but that program did not go forward. So, at this point, I would not use it for anything except for acyclovir-resistant HSV.
Yeah, and if I may add also to Christina, it is, if for compassionate use to access the drug, you have to have resistant or refractory herpes simplex. But for in the clinical trial, and we have one active at our site, where there is one arm where you can use it if patient are intolerant, or they have nephrotoxicity or intolerant to foscarnet. So then you can do platelivir in this kind of patient in order to get to gather data on safety and effectiveness in this kind of situation before you get to the resistant or refractory part of herpes simplex.
Okay, Roy. So tell us about new drugs for CMV infections.
Yeah. So we talked earlier about letermovir for prevention. It really changed the landscape in allotransplant, at least. We've been using it for prevention. It worked very nicely. It's safe. It's effective, and reduced the amount of CMV reactivation, as well as actually interesting data on all-cause mortality. Actually, it reduced all-cause mortality. Recently, it's been now, I would say, a little bit more than a year, where a new drug, maribavir, was also FDA approved for resistant and refractory CMV infections after stem cell transplant and solid organ transplant recipient as well. And they have to have specific criteria to enter into the trial. So it was approved by the FDA. It's available now commercially. It has different mechanisms of action than all the other drugs that I talked about for CMV. It inhibits actually UL97 directly. And by inhibiting UL97, which is the kinase, it works, on, reducing morphogenesis of CMV, on the egress phenomenon, and later on. So it's a late phase of CMV reactivation or DNA elongation. That's how it works. And the reason I'm mentioning this mechanism of action, you have to be careful, because what I mentioned also earlier, ganciclovir need UL97 to be phosphorylated. So if you inhibit UL97 with maribavir, you cannot use in combination with both, because of the antagonistic mechanism of action of both, where you inhibit UL97 and ganciclovir UL97. So I want to make sure that the audience or the listener is clear about that. We cannot use it in combination. So this new mechanism of action actually, it's an oral drug available now, where we use it in this kind of refractory and resistant cases of CMV after transplantations.
Okay, and in your expertise, in your experience, how effective is this drug, and what the data is out there?
Yeah, so we start using it. Actually, I'm going to talk about a little bit about the real world data, not the clinical trial, which shows that it's superior to the investigated assigned therapy, which is the old drugs. But in real world data, actually, maribavir, it is effective. It worked very nicely, but it's not the magic bullet, or it's not the perfect drug. We don't see some cases, which are very hard to treat cases. It may not work out of the bag. So you have to be patient. You have to treat with maribavir probably for a long period of time to show some effect. And sometimes you may not. But it is better than the other drug that we've been using for a long period of time, which are pretty toxic drug. And maribavir is pretty safe, not much of serious toxicity. The only side effect or main side effect from maribavir is dysgeusia, which is the taste disturbance from this drug. But no myelosuppression, no nephrotoxicities. So at least we have another option. safe enough. But I will also ask people, if they're going to start using it, don't wait until it is kind of too late, or it's at the point of no return where patient is very sick, then nothing else gonna work. I will use it probably a little bit early on when I'm suspecting resistant or refractory infection.
That's great experience. Any other drugs in the horizon at the moment that we may get there? Christine, let's talk about HSV. Any other drugs there in the pipeline that we may get to see in the clinical realm at some point?
Yeah, so there are other helicase primase inhibitors being developed. One is called IM250. It's in really preclinical phase right now, but that could be another agent. In addition, there are some early phase studies of monoclonal antibodies. Whether that would really apply to a transplant population, unknown, but I think that could be exciting potentially in the future if they're shown to be effective. And then the other area, it's not a direct antiviral, but there's a lot of interest in therapeutic vaccination and using vaccines to prevent HSV reactivation and disease in people who already have HSV infection. And
we'll talk about that in a minute.
Okay.
So that's kind of the great segue for the closing of no antiviral therapy. How about CMV drugs in the horizon? It's been pretty active in the few years for CMV. Are there more things to come?
I would say for a antiviral agent, there was another drug called brincidovir, which is a prodrug of cidovir, but did not work really for prevention of CMV reactivation. There is another strategy which is still in the early phases or phase 2, and probably there is one phase 3, which is the CMV specific T cell. And usually this kind of strategy or intervention, it is you leave it for resistant and refractory CMV. So patients not responding to the drug that we have, you may give them CMV specific T cell. We have some experience with that. It worked, in some of our patients, and it could be something in the future that we're looking forward to see in larger study to see the effectiveness and their safety.
Okay, great. You guys have moved to that area now. So let's talk about. So of course we are in a pandemic and a different phase of a pandemic, but we talk a lot about monoclonal antibodies. So everybody will ask, monoclonal antibodies seem to be very effective against these respiratory viruses. Why can't we have monoclonal antibodies for HSV or CMV? So what would you say to that question, Christine, to start with?
Yeah, I think I hope that we will get some monoclonal antibodies for HSV. It's definitely, possible to prevent infection or reactivation, we would think, by using a monoclonal antibody. So I think it would be really exciting to study that. I do think the monoclonal antibodies, it is different from a SARS-CoV-2 where you're preventing infection or severe disease for people who have an early infection. This is a little bit different when people are reactivating a chronic viral infection. That may be a lot more dependent on T cells. So I think we do have to pay attention to the differences between preventing infection with a monoclonal antibody and then how effective it would be, for instance, in this setting, someone who already has HSV infection undergoing transplant, would antibodies prevent that reactivation? That's an open question.
Right. Are there any monoclonal antibody in the pipeline that you are aware of?
There is one that is moving into phase 1-2 trials.
Okay, great. How about for CMV, Roy?
So for CMV, actually, we tried. There's one monoclonal antibody that we went through phase 2, probably around before COVID, before the pandemic, and did not work for prevention of CMV for different reasons I'm not going to get into. To my knowledge, I don't think there is much going on in the monoclonal antibodies. And I agree with Christina. Usually when you think about monoclonal antibody, either you want to use it prevention or early on in the infection, not later on when you have established disease. So there's not much going on in my, to my knowledge, in that area. But CMV vaccine, probably, I don't know if I want to leave it to the end.
Yeah.
This is
That
something, yeah.
hold your horses on that. So let's talk about, you mentioned about these T cell directed
Yeah.
therapies, right? That
Yeah.
which are interesting from the immunological point of view. So let's talk about, are there any approaches with T cell therapies for HSV infections?
I'm not aware of any. I don't know, Roy, if you're aware of any development that's going on.
No, not for HSV. There is one trial ongoing for multiple viruses. If I remember well, it's ABV, CMV, I think adenovirus, but I'm not aware of herpes simplex. I don't think herpes simplex is part of it. So it is taking some tractions for other viruses to treat or to prevent.
Okay, so Roy, you mentioned that's used for CMV. So let's explain the audience, how do you get these T cells, or where do you get them? How do you get to use them?
So it is third-party T cell where you isolate, CMV specific T cell with specific HLA type, and then it says on the off shelf that you can use it if they match with the patient HLA as well. So it is a kind of tedious phenomenon or tedious process in order to be able to generate, to multiply this CMV specific T cell in order to be used in patient in the future.
Okay, so and the data are really out there because it's so difficult to get enough numbers of patients is difficult to assess. But I want to get to the last point, which is what everyone is waiting. So vaccines, and I think there are a lot of movements now in viral vaccines with these new technologies. So let's talk about HSV vaccines, Christine. So how are we doing with those?
Yeah, so we are entering a new phase, I think, around excitement for mRNA vaccines for HSV, as well as hopefully some more traditional approaches to HSV vaccines, such as subunit vaccines. I do have to say that for HSV vaccines, similar for CMV, there are two different approaches that we really look at because it's a chronic viral infection. So we are looking at prophylactic vaccines, which is traditional approach to prevent infection. And then we're also looking at therapeutic vaccines. So using a vaccine to treat infection in someone who already has it. And the only analogous vaccine that we have like this is the shingles vaccine, which prevents reactivation among people who have already been infected. So there are some trials that will be starting up or have started in early phases for mRNA vaccines, both as well as subunit vaccines, both for prophylactic and therapeutic indications.
This is very exciting. Now we're seeing vaccines for RSV that we didn't have before. So how about CMV? Are we getting excited with CMV vaccines as well?
Yes, absolutely. Especially with this mRNA platform that Christina mentioned, gonna hopefully, can we generate a CMV vaccine could be pretty effective in immunocompromised patients, right? Because we have to keep this in mind. But also the approach gonna be different, as Christina mentioned, that it's not really to prevent acute infection or primary infection, but if you have latent infection, can we augment your T cell, CMV specific T cell response, even your B cell as well, in order to keep CMV into check and not reactivate? So it's gonna be probably, hopefully, if we get some trial ongoing in our transplant patient, it could be used as a combination strategy, not by itself, or maybe later on, in order to make sure after patient go through transplant, now can we give them the vaccine to make sure they're not gonna get late CMV infections, especially if they don't have enough CMV specific T cell responses as they go through the transplant? It's very exciting time for us in the world of virology. I would say we learned quite a bit from this COVID-19 pandemic. So hopefully to keep us busy doing the trials and having something different for our patient, because they really suffer from these infections.
I know, and these patients, have been, battling very bad diseases that one of these viruses can really kill them very, very rapidly. Well, I've learned a lot today. So what the future holds for the field? I'm going to start with Roy. I'm going to give Christine the last word.
Okay. So I think for CMV it's very exciting time. We already have two drugs recently approved. It took us more than 20 years to have this new drug approved for prevention or treatment, but still there's some unmet need. So we're not going to stop there. There's a new strategy in place. We talk about the vaccine, about CMV T cells, infusions, and hopefully others will come into play and learn more about this virus. This is a very tricky virus, big respect for it, but he's not our friend. So we need to keep it tamed and in check.
Christine?
Yes, I would say we're in the HSV world, we are really excited about the future. A few steps behind the CMV world, but really hoping to have new tools to treat and prevent the infection. And I think really realizing that patients still are suffering with HSV infection. So hopefully there will be interest in developing these further tools to really augment patients' lives.
Well, with that word of optimism, I love to close the podcast like that, in an optimistic, world that things are going to move forward. I want to thank you guys for taking the time to teach us about these very complicated infections. We've learned a lot. And thank you very much for your participation. And this concludes today's podcast. This is Cesar Arias, Editor-in-Chief of AAC, signing off.